he is an associate professor in the School of Psychology. He's also the director of the Vulnerability, Trauma, Resilience, and Culture Research Lab, V-TRaC Research Lab. And he holds the research chair on Black health at the University of Ottawa. His research program explores factors associated with vulnerability, trauma, and resilience, with a particular interest in the role of cultural factors. Dr. Cénat conducts research on the racial disparities in mental health and social services, the impact of natural disasters and infectious diseases on mental health, interpersonal and non-interpersonal trauma, and global mental health. He conducts research in North America, in Europe, Africa, and the Caribbean. And he leads a major project on the mental health of Black communities in Canada that has allowed for the development of online trainings designed to equip mental health professionals with the knowledge needed to provide culturally appropriate and anti-racist care. He's also a fellow of the Royal Society of Canada's College of New Scholars, Artists, and Scientists. I can't wait to hear him. He's going to be talking about racial complex trauma, the mind, the body, and the heart. So let's give him a real round of applause. And let's not forget, he's probably the driving force behind our gathering today. So thank you. If I had flowers, I would give them to you right now.
When they asked me to speak today, normally I'm supposed to say no. And it is the last time I accept, because it is really hard to organize and also speak. And the second thing is, they asked me to talk about racial trauma. I give a title, and then I change my title. I want to really talk about, because of the necessity to reclaiming the path to joy, I wanted to talk about anti-racist practices, because I really think it is something that is important, and we usually talk less about the practices themselves, but also to share results about what we are doing and the trainings, what are the results on the ability, the capacity mental health professionals have to share, to provide anti-racist care. So then I choose to title my presentation "Complex Racial Trauma and Anti-Racist Practices in Mental Health," but also to put the focus on the liberation aspect, because I do think as mental health professionals, sometimes we said like we are trying to liberate our clients, our patients, but first it is important for us to liberate ourselves. And I'm sure if we liberate ourselves, our clients, they will do the same. I have a lot of stock, so I will go fast. Since I started the Black Mental Health Project, the Black Mental Health in Canada project, I have been frequently approached by Black individuals across the country, many times after seeing other psychologists or psychiatrists. They describe the care received as culturally inappropriate or racist. I have been particularly intrigued by a portion of the people who contact me, a young Black father between 30 to 40 years old, who describe their psychological distress while apologizing for feeling bad. I'm sorry. I'm sorry, but I'm very sad. I still manage to get up in the morning to go to work only for my girls. I don't know how much longer I can do this. I'm sorry to write all of this, but it's not easy. I took in care a 34-year-old Black man, married with 2 children, an accomplished professional. He was born in Canada with both parents from the Caribbean. He never found his place in society. I At school, he experienced racial discrimination from students and teachers. For a year, he was called Cubicle the Black Genius by a teacher who also called him my black blind man because he wore prescription glasses. In university, he also experienced racism and often did his group projects alone because other students refused to work with him. And I think it is an experience some of you shared here. The first day I saw him, he was ashamed of having to consult a psychologist. I'm not weak, bro. I'm sad and tired of receiving racist comments from my boss and colleagues, tired of justifying I have enough skills to be the manager of my project, tired of hearing teachers treat my kids as I was treated as a kid. I'm not weak, bro. I'm sad, I'm tired, and I think I'm going to explode. And what I can tell you about this also is the fact that when you experience racial discrimination, you can develop racial trauma. And racial trauma is refers, I will say traditionally, to the fact that, first, let me say some words about the trauma. The trauma is an emotional response to a terrible event. There's an earthquake, and you are there, and it is a shock for you. In French, we say you almost encounter death, and there is no place in your psychic for death because no one encountered death and came back to tell you what it is. And you almost encountered death. And then it is a traumatic space, there's a traumatic experience. And this emotional response is the same when people experience racial trauma. And myself, I do think when we refer to racial trauma traditionally, it is mental and emotional damage caused by encountering racial prejudice and ethnic discrimination, racism, and hate crimes. But there is a need, I will say, to explain to people that racial trauma is trauma. Racial trauma is trauma because when you look at these results, for example, if you look at there, you will see we put the traumatic events. Usually, traumatic events is the most important factor to explain post-traumatic stress disorder. And when we put a traumatic event, we have a variant explained, which is 26%. And then we put three variables related to racial discrimination. And then we have 52% of explained variance. So variables related to racial trauma better explain post-traumatic stress disorder than compared to traumatic events themselves. So racial trauma is trauma. And when you look at all of these articles, you will see it explains depression, psychosomatic symptoms, but also low self-esteem and suicidal ideations. And on on depression, I give that number yesterday, and when you compare those who experience very high level of racial discrimination to those who experience the references low for this racial discrimination. And then you will see those who experience the very high level, they were more than 36 more likely to report severe symptoms of depression compared to those who experience low level of racial discrimination. So racial trauma is trauma, but also there is a need to say racial trauma is more than trauma. Why? Because it is, first of all, it is historical. it is historical and based on something. What it is, the fact that there is a consensus in some communities to say Black people, they are inferior compared to white people. Racialized people, they are inferior compared to white people. And it is not something that is, there is book on that. Actually, the Kobigo, he wrote a book, we are talking about more than 100 years ago, and he said, like, it is the inequality of human race, the inequality. And then Antonio Firme answered to him about the equality of human being. And he showed that, yes, we are the same. And he showed why, scientifically, why we are the same. But also it is intergenerational. When you experience it, you pass it to your children. Even you don't talk about it in silence, you pass it to your children. You have this conversation with your black young man. You explain them about the attitude with the police, and all of that, you pass it. But also the fact that racial trauma, we can say it is complex. And a lot of my colleagues, they will say, "Oh, Jude, just call it complex trauma, and that's it." Because yes, it is complex, and let's say complex trauma. But we cannot just say complex trauma because of three things. First, its origin. It is based on something you cannot get rid of, your skin color. Racial trauma is founded that on the fact that we try to classify human race. We try to classify human beings based on their skin color. But also the fact that usually when we talk about complex trauma, it doesn't go beyond adolescence. In that case, even the Black elders, they continue to experience racial discrimination in our healthcare system, for example. In fact, when you have your mom, when your mom wants to go to hospital, you accompany her. Why? Because you don't trust the healthcare system. And also, one of the things which is very important is the internalization. You already heard that Black folks will say, "Oh, you know, yeah, our newer neighborhood is a good one. Oh, there is just white people there." And you repeat for him, "Oh, yeah, it is a good neighborhood because there is no Black people, no racialized people, and just white people." And you say, "Oh, no, not what I'm saying. This is what you said." You internalize it, and in a way that you think what these racist people tell about you, it is true. And a good neighborhood is a neighborhood with no Black people. And these aspects make me say that complex racial trauma is something that we cannot compare to just complex trauma. And racial complex trauma is really complex, but also it is racial trauma. And when you look at this figure, you will see first the fact that all we can experience in terms of racism, but also its impact on mental health, anxiety, dissociation, chronic stress, depression, low self-esteem, but also in terms of physical health, diabetes, chronic headache, but also premature death. And also the fact that it impacts your way to interact with your relationship with yourself in terms of self-esteem, your relations with others in terms of romantic relationships, but also social relationships. Those who experience complex racial trauma, they have more difficulties to be in a stable romantic relationships. And all of these aspects also are related to first historical trauma, intergenerational trauma, and the fact that it impacts your social development, and it is not just a short-term impact, but long-term impact. And what is also more important, we have this feeling it is inevitable in the society, but what we are sure it is repetitive, but also it is cumulative. And I published this article on that where I explain what is complex racial trauma, but also the theory and also how we can assess it and treat it. About evaluation, I just put that too, and I really think we need more than that in terms of evaluation, because when the evaluations we have now, they just evaluate the psychological aspects. But we need instruments that can evaluate the psychological aspects, but the social aspects, but also the physical aspects and the economic aspects, because those who experience racial trauma, they have difficulties to get a job, but also difficulties to continue to work. And in terms of treatments, I really do not have time, so I will just say some words on that. The first is we have some papers on treatment of racial trauma, and I will note multiple things. First, the safety. It is important to feel safe to be able to talk about that. But also it is important for us as mental health professionals to acknowledge it. Because usually when people come in our clinics, in our office, what we do is to avoid it. When the person talk about racial trauma or racism, we try to avoid it. Why? Because we were not trained. Even you are Black, you were not trained to address racial trauma. Even you are Black. And sometimes we blame them. Are you sure it is exactly what the person said? Maybe it was not that, and maybe it was not intentional. And when you do that, the person feels bad, and he or she or they will not talk about that again. And also the resistance strategies, because it is important to be inspired by liberation psychology and try to empower our clients to improve their lives and to be able to cope in this kind of situation. And maybe I will, but in terms of anti-racist practices, where we are in 2024, we published that article, which is a systematic scoping review, where we were trying to see what kind of training programs we have for mental health professionals which are anti-racist. And we included 30 papers, and we found 3 core competencies. The first one is the knowledge of cultural, social, historical context of mental health problems. Because when we are talking about racialized people, Black people, for example, it is important to know where it comes from. Why we have some people in our society and we think they are inferior in the society, where it comes from, but also to understand all the clients internalize racism also, and also self-examination. And self-examination is very important because it is important to recognize how oppressive are our practices. It is difficult to address them. I know it is difficult to address them, but also we need to analyze ourselves as a mental health provider, where we come from, our family beliefs, our social and racial advantages, and how we can address them. You come from a racist family. Your father was racist. Your mother was racist. They had racist comments each time you were eating on your table. And you think after this, oh, myself, I'm not racist. I believe you, but you have a work to do with yourselves to go beyond all of this, because sometimes, okay, I'm not racist. I'm good. I'm not racist. I have black colleagues, you know. And Dr. Mila actually will ask you, okay, you have a lot of black friends. That's cool. What is the last time you invited them home? Oh, never. Okay, what is the last time you invited the children to play with your children? Never. And they are your friends. Maybe they are not. And sometimes you have a friend from Harvard University, who is a professor at Harvard University, usually said, some people are not racist until they have their son or the daughter who wants to marry a black man. And it is important to analyze ourselves, but also to have anti-racist competencies, verbal and non-verbal competencies, and also to try to have multicultural, transcultural competencies. And on that, I will let me go from there. I published this article, How to Provide Anti-Racist Mental Health Care. And then it became the training providing anti-racist mental health care. And with 5 modules, the first one, it is on analyze ourselves, analyze his own racial and cultural biases, recognizing disparities in mental health care, also developing cultural competence. And the second one is on, it is concentrated to how we can provide anti-racist assessment. It provides a way to assess racial discrimination and its implication for mental health. And the third one is a humanistic approach to medication. Even you don't prescribe yourself, it is important to still have, to know about it, because maybe you have a black adolescent with psychosis and they don't want to take the medication, or maybe ADHD and the parents don't want to give the medication. And let me tell you, usually they are praying and they ask the kid to lie to you saying, I'm taking the medication, but they don't. And why? Because they don't trust us. They don't trust the system. And they are right to do not trust the system. And it is our role as mental health professionals to secure them enough to make them trust the system. And the fourth module is interventions adapted to racial issues. And the fifth one is providing tailored anti-racist mental health care to children, adolescents, and families. And then some results. We implemented that training. We implemented that training to this is like school mental health providers, multiple, more than 7, I think 9 school boards. And what we found was it is on 319 mental health workers. And what we found is, but it is not just implement the training, but also with pre-tests, post-tests, and testing follow-up, but also having clinical supervision sessions for the school mental health providers. And then what we found, first, it helps to improve cultural competence, multicultural competence. It helped to improve it. And after 6 months, that people, they still have good multicultural competence, which is something that is good. And also, we did the same with cultural humility. And for cultural humility, it is the same, and it helped them to improve the cultural humility. And there is just one case in self-awareness, because before they took the training, they think they know well about racism. Then they took the training and they see they said, oh, okay, we know less than we think we knew. And all of this after after 6 months after the training, it was still okay. And then these data, they are not mine. They are from New Jersey, actually. And I'm happy that the colleagues sent them to me. What I want you to know about this data is the fact that we are trying hard to implement the training in hospitals here in Canada. Even we got money for it, it was impossible. And the training is implemented in New York. We have contract with New Jersey hospitals to implement it. And now they have really good data we don't have in Canada. And in that case also, what they did, they have a book. They called it a book club. It's more a reading club, and where they talk about the training, but also publications on that. And also they have 3 clinical supervisions per month, and where they talk about racial aspects. And you can see the results are really almost exactly the same. And we found the same pattern here, where they think first they know more about racial issues, and then they see they knew less than think they did. And now we have a second version of the training. We have a new website, and where we have videos, video case studies, and where it is really a great experience now. And you can go to our website, Mental for Everyone, to take it. And then 5 minutes. Oh, I have a lot of time. Then Angela, Henny, and I, myself personally, a lot of people ask me, okay, you have the providing anti-racist mental health care training, but what we really want is the anti-racist CBT, because it is the approach we usually use. And then we published this article with Angela and Monica on providing anti-racist cognitive behavioral therapy. And we give guidelines, tools, and tags, because myself, I really believe that CBT is maybe a real good approach to treat racial trauma and to treat people from racialized communities, because it is non-judgmental. It is a collaborative approach, and it is emphasis on the empowerment of the client, and we can better adapt it to cultural but also racial issues. But what we want also to need to know is the fact that a lot of studies showed that CBT did not work well for people from racialized communities. And it is important to know why. And I think there is 5 failures of CBT theory and research, but also approach in general. First, the concept of neutrality. Because if I tell you I experienced racial discrimination, how can you be neutral about this? Because for example, let me just give an example. Sometimes we have to put words on what our clients and patients are telling us. The person said, oh, Let me give an example. The first time, like this young woman, young woman, she was great, good professional, and I saw her many times. And one time she came to my office and said, Dr. Cénat, I'm tired to be Black. I said, oh, okay. And then she explained me her day. She was on phone many times, sending many emails to someone, set up the contract for her company. And the person came for the first time, and the person said, oh, 2 minutes. Oh, you are Black. Oh, you are smart. And I will never think you are Black. The day starts like that. And then her boss said to the same person, oh, she's our Black intelligent person. And all of this during the day, and then she came, it was 6, and she told me, I'm tired to be Black. This is the Black fatigue. So you cannot be neutral on that. Also, the universality. It cannot be universal because we have different cultures. And also the Eurocentric biases embedded in CBT theory, but also practice, and also the inequality of the triangular model taught emotion behavior, but also the colorblind approach promoted. And in Canada, we are particularly colorblind. And usually people say, oh, you know, I don't see your skin color. But if my skin color is part of my problem and you ignore my skin color, it is a racist attitude. So if I came and I tell you like, oh, okay, I come and I tell you, I have this problem, and you know it is related to the fact that I'm a Black man, tell me about my skin color. Tell me about my skin color. And this, so how to provide anti-racist CBT? And the first one is to assess ourselves. The first question, are we racist? Am I racist? What are our own racial biases? We all have biases. And let me tell you, your biases protected you. If you see a car and say, okay, let me go there, that protects you. But we have those biases we have also to know about them. And do we know them? How do we deal with them? How do we address them? What are our skills in strengthening vulnerable communities and people in our CBT intervention? But also having this intersectional approach to include race, gender, sexual orientation, religious beliefs. Monica, there is a paper just accepted by Monica on our data, and it is on Black women, Muslim Black women. What we found was, okay, if you are Black, you develop more depression. But if you are Black and women, you develop more depression than Black men. But if you are Black, you are woman, and you are Muslim, you develop more depression than Black men and then Black women. Why? Because when you are Black, when you are Muslim Black women in Canada, there are religious discrimination against you, but also racial discrimination and gender discrimination. So also develop anti-racist care competencies as a clinician. And the last one is the triangular approach, which is not work. And I think it is important to also include the environment, so the social context where people evaluated. So do not conclude. Do not forget all our phrasing, race relations, racial chasm, racial justice, racial profiling, white privilege, even white supremacy serves to obscure that racism is a visceral experience that dislodges brains, blocks airways, rips muscle, extracts organs, cracks bones, creates teeth. And this is what Tennessee Code said. And when you experience racism the first time, you still remember it. And I wanted to finish with the black man, but I will not do it. I want just to repeat what Lashe said. Yes, not everything that is faced can be changed, but nothing can be changed until it is faced. We can do it. There is ways to do it. Now we know. We cannot say we don't know. And in the meantime, we have to celebrate us because of who we are. We are beautiful people, beautiful black people. Let's celebrate us. And when you think to go somewhere, always remember what W.E.B. Du Bois said, go where you are celebrated, not where you are tolerated. Thank you.
All right, thank you so much. That was such an enlightening presentation. For starters, are you going to share those slides? Or you moved pretty quick, so I'm wondering, is that something that you're able to share? Okay, thank you. And so that helps because my writing is squiggly. So thank you for sharing that. So the question I had for you is, given that racial trauma is ever present, so it's when we're thinking about PTSD, traumatic stress, whereas racial trauma is ongoing, it's ever there, especially as it relates to anti-Black racism. Is there work being done to have that included as part of the DSM-5? Because with an official diagnosis, there comes pathways to access to the medical system, to EI, and all the other things that come with a proper diagnosis. So is that something that's in the works? Is there a way to help push that to happen? Yeah, that's my question.
Context. And what we want is something that is clear. It can be based on your racial background. It is not clear, and I think we still have to push and really push on that. What we want to know is we need to be there. And I really think we need to be there. Not the case, still.
The article about, I'm wondering, is that article by you?
It is published 2 months ago, something like that.
2 months ago?
2 months ago, something like that. Propose is really a panel with.
We have about 1 more minute.
Oh, there's.
Toujours un plaisir, Dr. Cénat. Merci beaucoup. Je formule ma question, puis j'en réfléchis un peu en même temps. Je constate que, évidemment, le rôle du racisme et du trauma complexe raciste est un thème qu'on voit qui est souvent universel ou omniprésent dans ce qui est présenté comme étant faisant partie de l'expérience des personnes noires, des communautés noires même, on pourrait dire. Ce que je me questionne, c'est que est-ce que dans notre grille d'analyse, la grille d'analyse devrait être davantage l'intersectionnalité? Étant donné qu'on ne parle pas de communautés homogènes, mais très hétérogènes. Justement, je parlais avec un des collègues au Cameroun, on parlait de nombre incroyable au niveau des différents dialectes, des cultures. Donc, je me questionne, est-ce que, puis je pense que la docteure l'a nommé ce matin, comment que même le racisme est un phénomène nouveau pour une personne qui est issue de l'immigration récente. Donc, est-ce que qu'on parle des approches au niveau des communautés noires, est-ce qu'on se limite, en fait, qu'on parle du racisme? Est-ce qu'on devrait prendre une lentille un peu plus reculée, puis même commencer avec une grille d'analyse qui est beaucoup plus intersectionnelle pour tenir compte de la complexité? J'espère que ma question, je la formule un peu en réfléchissant, mais j'espère que ma question fait du sens.
Ce que j'ai essayé de dire en parlant de l'exemple de l'article de Monica qui vient d'être accepté sur le fait qu'on a la différence entre être noir et femme et être noire femme et musulmane. Donc, il y a une nécessité d'intersectionnalité. Après, il ne faut pas non plus se cacher la face non plus. C'est dire, quand on est face au racisme, il faut savoir le noter et le nommer surtout. Il faut savoir le nommer. Après, il ne faut pas non plus que tout soit lu avec ces lunettes-là. Quand j'essaie aux étudiants, je leur dis, tout n'est pas culturel, comme tout n'est pas forcément raciste. Et ce n'est pas parce que quelqu'un pose un acte raciste que la personne avait forcément des intentions racistes. Par contre, si l'acte est raciste, il faut traiter l'acte comme tel. On ne peut pas non plus dire, ah, c'est du racisme, mais ce n'est pas du racisme parce que la personne n'avait pas d'intention raciste. On va traiter l'acte en tant que tel et puis après, on verra avec la personne. Mais c'est important de reconnaître ces aspects-là parce que si on ne les reconnaît pas, après, on est face à une situation où on n'arrive pas à noter les choses. Je donne un exemple simple. Mon épouse travaille à un endroit, dans une université. J'allais dire non. La personne responsable du vice-rectorat à la recherche lui sort, elle s'appelle Rose. Puis la personne lui dit, oh, ma rose grillée. On peut dire, OK, ben c'est pas du racisme, c'est quelqu'un qui a voulu être gentil. Mais de fact, ça a gâché toute sa journée. Et aujourd'hui encore, elle en parle. Et j'ai l'impression que si c'était légal d'arracher les 2 oreilles de cette personne, elle le ferait. Et quand on dit ça, pourquoi on le dit? C'est que c'est une situation où quand quelqu'un vous appelle comme ça, et puis la personne appelle les autres personnes correctement. Et donc, il faut appeler le racisme par son nom, mais quand on doit traiter de cela, on sait que c'est complexe, il faut rentrer dans toute la complexité de la chose pour pouvoir la traiter et ne pas faire en sorte que, ah ben tiens, c'est comme quand il y a eu le mot en haine à l'Université d'Ottawa. C'est trop facile de dire, OK, on prend telle décision, on prend telle autre décision. Et bon, quand je dis ça, ben, ne mettez pas des personnes racistes dans des endroits où ils doivent prendre des décisions contre le racisme. Ben, à ce moment-là, ils deviennent des personnes radicales, ils prennent des décisions où on se dit, oh, OK, ils prennent des décisions beaucoup plus dures que ce qu'ils devraient prendre. Pourquoi? Parce qu'ils sont en train de se protéger, parce que, voilà. Je ne vais pas en dire plus. Yes.
Hi. Two things. Research out of Nova Scotia is showing us that the concept, of restorative justice, which a lot of people want us to do, it's not working in Black communities. And it's not working precisely because of what we're talking about today, is that people, they've got that history of what has happened. You say, well, let's talk about this incident now in restorative justice. And people want to talk about their pain. They want people to understand how it got here, and just come in and telling me, you're sorry because you hit me, or it's not working. So within the Black justice strategy, that isn't working. But I want to give you a quick story, because I'm a storyteller. My daughter was on a Zoom call with somebody. And one of the people on the Zoom call was a vice principal. And my daughter could not remember how to say "en bonjour," just hang in there. So she said to someone, how do I say this? And they said, lâche pas la patate. And the woman, the vice principal, and they were talking about children, elle a commencé à chanter. Et la chanson qu'elle a chantée était, and you can tell when I speak to French to work about things like that, because it hurt me so much, I push it away by talking in another language, and another colonial language.
We are all speaking the colonial language.
And la madame a commencé à chanter, et la chanson était lâche pas la patate, mon nègre, lâche pas la patate. Et ma fille a répondu en disant, you know what you're saying is racist. And she said, no, it's not racist. J'ai appris la chanson de mon grand-père. And apparently it is a song that they used to sing. So they went on the internet And they found the song. It's a song from Louisiana. And the man is still there singing the Kafatsta song, Lâche pas la patate monnaie. Ma fille, elle a fait une plainte. And she complained to the headmistress of the school. And she said exactly what we're talking about. She said, listen, she didn't mean it that way, and you should stop taking it that way. You're causing problems. And that is, that you don't get heard. And when you get told that, you retreat into yourself and you internalize some more. You start questioning yourself. Ma fille m'a demandé, she said, Mama, am I wrong? Was I, did I do something wrong? Did I misunderstand? Because I complained, and even the principal is telling me that there's a problem with me. So, and those are the kind of, and the last thing is I dislike the term microaggression because there is nothing micro about the pain. I don't use that term. I just go aggressive. En tout cas, merci beaucoup. Wonderful speech.
Thank you. Thank you, Dr. Minalache, to say the last words for me. Thank you.
A correction to make.
Now we have the sessions. We have, I think, 7 minutes break. I'm sorry, 7 minutes break, and then we have to join the sessions. And do not after, maybe I have to say that if you see the program, we have a real important discussion in CISN 5 to 7 with people from Ontario Health on Black Health, and it is like a gala. It will be in the same room where we eat. Okay? Thank you.